Good morning, Dr. Pankaj.
Yes, sir, we are live.
So, good morning, respected faculty and dear delegates. We are having third session of Master E-classes in Cardiology today. Speaker will be Dr. MUNESH Tomar. We welcome the chairpersons, Dr. Sukanta Chatterjee and Dr. Deepa Firke ma'am. I request our President, Dr. Pankaj Garg sir, to please say a few words.
Good morning, everybody, all delegates, faculties, and coordinators of this program. First of all, Dr. Ajay, who has been spearheading our academic activities for last few years, and we have been conducting e-master classes in various specialties, and now we have come to the pediatric cardiology. Pediatric cardiology is a niche field in which we feel that there's something more needs to be done than routine what we are taught in our MD pediatric days. So that is why this course is very important. And we had two classes in the last 2 weeks when we discussed how to clinically approach cyanotic and acyanotic congenital heart diseases and acquired heart diseases with the help of clinical examination X-ray by Dr. Neeraj Agarwal and then by ECG by Dr. Atul. Now is the time for actual discussion on the disorders, and that is why we have talk on complex congenital heart disease cyanotic variety by Dr. Munish Tomar. I take this opportunity to welcome Dr. Shukant and Dr. Deepa. They're all very esteemed senior members, CIP, EB members of our country from West Bengal and from Maharashtra. I welcome both of you on this program. You took out your precious time to come to our platform of IIP Delhi to understand that IIP Delhi is doing a lot of academic activities and to partner us in this noble work. These definitely, I'd say, we're going to be a very, very interesting session. I know Dr. Munish for many, many years, and I know she's a great orator and a great teacher. So we'll really welcome you, Dr. Munish, and we'll really look forward to a very important discussion today. Thank you so much, and over to Dr. Ajay for proceedings.
Thank you, Dr. Pankaj. I request Dr. Neeraj sir to please introduce the speaker and the chairpersons.
So, I humbly accept that this is a very good session going on right now. Last two classes are very good actually, and the speakers have been excellent. Along with the inputs of chairpersons, we have been blessed. Today we have Dr. Sukanta sir. He was a former professor and head of department of pediatrics, Kolkata Medical College, and he's a esteemed member of lot of groups, coordinator, professional groups of adolescent sexual and reproductive health. He had been chairperson of Adolescent Health Academy, and he's certified on adolescent medicine, Boston Children's Hospital, Harvard Medical School, USA also. And he's author of multiple books on IP textbook of pediatrics, PG textbook. He has huge work on PG groups. He has been an excellent teacher for all, and we welcome him from our heart to this conference. Dr. Sukanta sir, welcome sir. Few words from you, sir, for today's session, sir.
I must say this is a very good initiative with this webinars, a learning opportunity, and also to interact with each other, our colleagues, in these days of say time and money constraints. So this is an opportunity we can just join and meet each other. That's a great opportunity, and at the same time science. That is also I must congratulate this initiative of Delhi IIP headed by Pankaj Garg sir. Thank you very much. And Ajay Gupta, whom we met frequently, Dinesh Goel and Neerajji, and my colleague in CIP EB, Dr. Deepa from Kolhapur, and today's the speaker, the star person, Munesh Tomar. Thank you.
Thank you, sir. Thank you, sir. I welcome our second chairperson, Dr. Deepa ma'am. She is the professor HOD, Government Medical College, Miraj. Ma'am has lot of teaching experience. Her special interest is pediatric infectious diseases. She has been PG teacher for years now. She has been past secretary, past president of multiple IIP branches like Kolhapur Academy of Pediatrics. She has been executive board member for years. She has been faculty for BLS, EPID, and infectious diseases. And she has been currently our central IIP member. Ma'am, we welcome you, and please we welcome some few words for today's session, ma'am.
Thank you. First of all, I thank IIP Delhi for inviting me for this interesting session as a chairperson. And I am very much fortunate to experience this master sessions. And I think this is the need of time now, where apart even after MD Pediatrics, the students and all the practitioners need to specialize themselves in certain branches. And I think this is one of the best platforms, because online we can connect everywhere, and just sitting at our home or institutes, we can upgrade ourselves. So this is a very good initiative by IIT Delhi, and I give my best wishes to all the organizing team, the speaker, ma'am, and the attendees. Thank you so much.
Thank you, ma'am. Thank you.
Thank you, ma'am. I would request our chairperson, Dr. Sukanta sir, to introduce the speaker. Sir,
Well, it's my privilege to introduce Dr. MUNESH TOMAR. Namaste, madam.
Namaste.
She did MD Pediatrics, the basic degree for all of us. And then she did fellowship from National Board in Pediatric Cardiology, and also fellow of American College of Cardiology. And more than 22 years of experience in the field of pediatric cardiology and congenital heart diseases. And present affiliation, she's Professor of Pediatric Cardiologist, LLRM Medical College, Pediatric Cardiologist, Nutema Hospital, Meerut, Visiting Pediatric Cardiologist, AIIMS Rishikesh, Chairperson, National Pediatric and Fetal Cardiology Forum, National NB Pediatric Cardiology Webinar Coordinator, and formerly she was Director of Pediatric Cardiology, Max Super Specialty Hospital, Delhi, and also in Medanta Hospital, Senior Consultant Pediatric Cardiology, Otis Scott Heart Institute, New Delhi, and she had published book on echocardiology in congenital heart diseases, a practical approach, and more than 114 international and national publications. Life member of many national and international organizations, just to name Indian Academy of Pediatrics, Pediatric Cardiological Society of India, India Medical Legal and Ethics Association, and also she was awarded the Best Student Award in MD Pediatrics, received from Honorable Prime Minister, and also Best Teacher Award in 2020 by UPIMA. I request Madam Dr. Manish Tomar to introduce the subject of today's congenital heart disease, which is one of the very interesting yet ill-understood topic from our undergraduate days.
Thank you. Thank you, sir. Thank you for kind words. And thank you, Neeraj, for giving me this opportunity. Very important for all of us, and for especially the students, to connect online. So like all the faculty, especially the chairperson or the speaker, can connect all over India by these webinars. And this is DNB. I'm doing for 4 years through DNB. And this is again important initiative. And all the states IAP are planning same way. So this is important, because cardiology is sort of somehow remain piche ho jata hai when we are doing our MD. So this is the way we can connect with our students, our colleagues all over India. So just going toward slide.
Yes, the screen is visible, but the presentation is.
yeah, now, yes.
And please, that's great.
So the topic, the child with cyanosis, I took little liberty removing the congenital heart defect, because cyanosis is cyanosis and it's more of the cardiology, but we should not forget about the non-cardiology issues simultaneously. So whenever we see a child with cyanosis or with low saturation in OPD, so we should not get panic. A systematic approach, history examination, investigation should be planned, and we can save a lot of these babies, whatever underlying factor there is. So this word was used around 3000 BC. It's a Greek word, cyan, which means blue, and the cyanotic, so-called cyanosis being used. Before going into the cyanosis, we should know what is the normal saturation. So normal saturation is more than 95, 95 to 100. Anything below 95 is something we should take it seriously. We should recheck, we should evaluate it. It could be benign or could be a serious underlying condition. And clinically, cyanosis is when the saturation is less than 85. So we always talk about less than 85, but between 85 and 95, lot is being missed. So there is value of using pulse oximeter in OPD whenever a child come to visit. So it is a bluish discoloration of skin and mucous membrane, and it is because of increased reduced hemoglobin content, and that is more than 5 gram. The various books mention, some says 3, some says, so 3 to 5 is the range which is giving in different definitions. So why it is 3 to 5, I will go to that. Or meth hemoglobin more than 1.5 or sulfur hemoglobin more than 0.5. So reduced hemoglobin is there to give the bluish discoloration to the skin and the mucous membrane. When the hemoglobin is reduced, hemoglobin is 3 gram, then saturation is below 90%. When it is 4, it is below 85%. When it is 5, it is 80%. So clinically visible cyanosis is at less than 85% saturation. That's why more than 5 gram of reduced hemoglobin is used to define the clinical cyanosis basically. To classify it more, it can be centralized. It can be central cyanosis, which could be generalized or the differential. It can be peripheral cyanosis. A part of that is acrocyanosis, which is we see in the newborn babies, and the pseudocyanosis. Because of discoloration or because of light, we may get that impression that limbs are blue, but which is not. So just to differentiate between the central and the peripheral cyanosis, periphery, warm, that could be cold. So periphery means because of vasoconstriction, because of any reason. It could be because of low cardiac output or because of periphery, the temperature outside is cold. So anything will lead to so obviously you will get a cold extremity. Mucous membrane, because it is central cyanosis, so mucous membrane has to be below, which is not a case in case of the peripheral cyanosis. If you apply the warmth, it will persist and it disappear in case of peripheral cyanosis, and saturation is most important part. So whenever there is doubt of the bluish discoloration, we should document it by the saturation. If it is normal, you can relax related to that bluish discoloration. Then comes the differential cyanosis. So for the arterial saturation, differential SpO2 and differential cyanosis, these are two words which our students need to understand. So differential saturation, when it is a difference of more than 5%, and differential cyanosis, obviously it has to be visible clinically, then it is more than 10%. Upper limb blue, whenever we'll call about the differential cyanosis, it is PDA is the culprit. So ductus arteriosus, which is shunting right to left, is the culprit here. So the PA pressures are severely elevated in this case. So when upper limb is blue, lower limb, upper limb pink, lower limb blue means PDA right to left shunt, Eisenmenger syndrome, or critical coarctation, interrupted aortic arch, or PPHN. So newborn, this is PPHN when we talk about the differential cyanosis or the differential saturation. So this entity should always be kept in mind when we are in nursery, but at the same time, critical coarctation, interrupted aortic arch should be there. So when we talk about the PPHN differential cyanosis, always the underlying critical structural defect should be there. So there comes the use of the echocardiography. Grown-up babies, PDA Eisenmenger will be the reason. When the upper limb is comparatively blue, saturation is lower in comparison to lower limb, then that is a transposition of great vessel with PDA, again pulmonary arterial hypertension. So pH with PDA is the setting whenever there is talk of the differential cyanosis. And this is grown-up lady, she was 32-year-old, diagnosed. For the first time, she was diagnosed to have cyanosis because only the lower limb was having clubbing and cyanosis, and the upper limb was blue. The saturation lower limb 76%, upper limb 94%. And now she was, after having 2 kids, childbirth, she was diagnosed to have PDA Eisenmenger. So this is something when the saturation is low or the cyanosis in the lower limb, it is very it is common to being missed, and that is the importance of checking the saturation in lower limb also, and checking the pulse in lower limb also. So anything below the arch level, so whether it is coarctation of aorta or PDA right to left shunt, we will miss if we don't feel the pulse, if we do not check the saturation in the lower limb. So cyanotic heart disease, we need to be careful because the serious the heart disease, the murmur will be lesser, and the cyanotic congenital heart disease without clinical cyanosis, if like as I said, between 85 to 95%, there will be clinically no cyanosis, or if there is anemia, the cyanosis will be missed. So these are the cases where we say cyanosis doesn't mean clinical cyanosis. Cyanosis means low oxygen saturation, and that obviously you need to have by the pulse oximeter. Acyanotic heart disease like the peripheral cyanosis may have mild desaturation. It is because very large torrential shunt leading to low cardiac output, and you may have the peripheral cyanosis, or like dilated cardiomyopathy where there is no structural heart defect, no right to left shunt, but because of very low cardiac output, you will have the peripheral cyanosis, and that is because of peripheral vasoconstriction. Body is trying to undergo peripheral vasoconstriction to maintain the perfusion to the core organ. So that will be a cause of, and here obviously you need to stabilize the cardiac from cardiac point of view, not to to put the worm to the peripheral, because that will the wormer, the behavior in this critical condition will deteriorate your child, because you are just taking the natural protection and you are putting the circulation to the periphery, which is being protected by the nature to provide the circulation to the core organ. So that is the value we need to understand. This peripheral cyanosis, because of low cardiac output, what the patient needs, he needs protection of the core organs, maintaining the blood pressure and maintaining the peripheral perfusion. So a balance has to be created in this condition. This is an infant came for echo for the failure to thrive. The main complaint was his weight was 5 kg at 1 year. There was no history of cyanosis. Other symptoms were there. Mother said baby is tachypneic, not able to take feed properly, but there was no history of cyanosis. And this was my echo. It was the transposition of great vessels, and this was the saturation. So even up to 50%, a saturation level of 50%, we can miss it clinically. So this is the importance of because at 5.5 gram, you hardly have the desaturation, how much you will have to cause the clinical cyanosis. So clinical cyanosis is being missed with such a low saturation. So we all have to vigilant for the so-called cyanosis so cyanosis is not the clinical, it is the use of pulse oximeter to label them as a cyanotic heart disease. So a very good article by Dr. Saurabh Gupta recently published about the cyanosis means it is a low saturation by the pulse oximeter. And this chart, I like this chart because that shows the relation of the hemoglobin to the clinical appearance of the cyanosis. When the our polycythemic patient, grown-up congenital heart defects like tetralogy, they come at 20, 30, 40 years of age, and they are severely blue. Saturation is 85, 87%, not that low, but they are very blue. And because it is very high hemoglobin level. So their hemoglobin is 27, 28, 24. So with that hemoglobin, and this red is the desaturated hemoglobin. Here it is being taken as a 3 gram per deciliter. With 3 gram desaturated level, his saturation is so good, but he is very blue. On the contrast, when child is severely anemic, even with the saturation of 62%, you will have a clinical cyanosis with around 10 gram of the hemoglobin with saturation of 60%, 62%. So this is the value of the hemoglobin in relation to the clinical cyanosis. So we can miss a lot of cyanosis if we do not use pulse oximeter if child is anemic. And this is very common in our Indian context to have a to have a low hemoglobin level in our developing area. So medical college patients, they come with hemoglobin of 4, 5, 6, or majority less than 10. And obviously, we are missing a lot of cyanosis if we do not use a pulse oximeter. Causes of the cyanosis: cardiac, respiratory, neurological, hematological, which we all are reading from our first year MBBS time of view. Cardiac baby is usually comfortable until unless he come with the added respiratory issue, and that is not uncommon. So they come with so-called URI, with then respiratory distress is being noted, then cyanosis being detected. This is the cycle which we most of the time see. Purely respiratory, they have severe respiratory distress, labored breathing. Neurological, it is because of hypoventilation. You can clinically make out that this is a neurologically child is depressed. That is the saturation is on lower side. This is 90, 92 sort of. And the hematological, methemoglobin, sulfamethemoglobin, they have cyanosis but no clubbing. So if there is no clubbing, child is significantly blue, obviously we can think of and they have a comparatively shorter history exposure to the drug in these cases.
Excuse me, ma'am. Sorry.
Yeah.
We have a few questions. One of them is, Best bedside pulse oximeter for neonate to children, especially portable. I think we all faculty, the chairpersons can answer this question. What do they think about the best pulse oximetry for neonates to children? Ma'am, your view. Munish ma'am, what do you think? What is the best? What do you pulse oximeter use?
Thing is, Neeraj, we should not use the adult pulse oximeter. The probe is important, brand is not that important. That is one thing, because there are advanced pulse oximeter for the newborn also. The most important is the probe, and majority of time that is the reason we are missing the correct saturation level in these patients.
Yes, ma'am. So for other, like Dr. Ajay sir, Dr. Pankaj is also there. In our OPD, there are like those who are cheaper pulse oximeters. They are all adult pulse oximeters. They cost you around 3,000 rupees. They are
Yeah.
really not useful to us. They are not really useful to us. And whenever we have multi-system monitors in the OPD like BP and cuff, they are good monitors. They have all the probes and they have good quality pulse. So any brand, as ma'am says, will be okay for us. They normally those who are high quality pulse oximeters, those who have multiple probes, the detachable probes are useful for useful, and they are portable. They all are portable. You can port them from one place to another place.
Yeah, they come at the size of like phone, and
Yes.
multiple probes. So
Yes.
for a proper fitting of the probe is very important. Newborn, pediatric, and adult, we can have 3 probes, and not that costly. Actually, it is worth to invest in these things: pulse oximeter and the BP apparatus. We all pediatricians should invest in that.
Regarding this cyanosis, visibly cyanosis, like if you ask for a DNB student, DNB pediatric student, when they see the patient, are they given pulse oximetry in the exams to
Yes,
check the saturations? Are they being given nowadays?
yes, we do give.
Yes. So we should give actually. Dr. Sukanta sir, what do you say about this? Dr. Sukanta sir, if he's around?
Yes, I do agree with this point that the saturation must be taken into account, because the between the 85 to 95, this stage we must identify for the management and also for the early detection of the disease that Madam has already mentioned. That's very important. But regarding the pulse oximeter, it must be the specification and the a specific model must be there, and it must be portable. That I fully agree.
Thank you, sir. Thank you. Munish Tomar ma'am, we can restart.
I had one question to Madam.
Yes,
Yes.
Well, there are many congenital cyanotic diseases where we don't get any respiratory distress. It's hard cause, definitely. But in spite of so significant desaturation and cyanosis, and hemoglobin being more than 10, rather sometimes mostly polycythemia, why there is no respiratory distress? Why respiratory center is sitting idle and adjusting all these things?
yeah.
That was an undergraduate question asked to me by a student. Sir, the cyanosis is there, but there is no respiratory distress. How can you explain it?
Yeah, sir, very good question, and thank you for asking this. The like our body is adjusted to the chronic diseases. Okay, so if you have a sudden deterioration in saturation, the child becomes symptomatic, like in the respiratory case. When it is chronic, the body adjusts to that, and our respiratory center and everything get adjust accordingly. Same happen for the blood pressure. If it is chronic, the adult come with the blood pressure of 200 by 100. It's not uncommon, but it is acute rise in hypertension. Patient become very sick, come with pulmonary edema. So chronic and acute deterioration in disease will precipitate the symptoms. That is very important. And the other thing is, these chronically cyanotic patients, they adjust their body. They don't exert. They remain in some comparatively sort of inactive state. They're just sitting, they're just lying in knee chest position. If you look at they're in bed, they're just always in knee chest position. So body is there to adjust for the underlying problem. So they very beautifully, like you look at the Down syndrome, they always go into prone position when they start turning. So natural protection is so beautiful. But anything over that, like any suppose infection or even mild fever, will deteriorate them, because that will disturb their hemodynamic. They can go into tachycardia and they go into cyanotic spell. Same way, just exertion with the crying will lead to tachycardia and they go into cyanotic spell. That is a very severe disease of severe presentation for the cyanosis. So naturally they are so-called balanced, but any precipitating factor will deteriorate them. So they are not,
Yes.
but they are trying to be stable. They are maintaining their life that way.
So even at rest, say a phallocytology patient is walking and all that, but there is no hurried respiration or respiratory distress. Perhaps the reason is the sensor at the respiratory center and others, they are accustomed with the fetal level of hypoxia.
Yeah.
And the respiratory center has never tested the 95, above 95, say oxygen saturation. Since it's congenital and there is no respiratory distress. That's the reason this, because it's chronic.
Yeah.
And another thing is that the clubbing doesn't appear immediately. It takes time to develop. That you will discuss subsequently, I believe.
And if you go into detailed history, the family always tell कि थोड़ा चल के फिर बैठ जाता है, थोड़ा चलता है फिर. So ये history है because they can't exert. They are not having resting tachypnea, but they can't exert. So that history of squatting is there when they start walking. It is.
Yes. Please proceed.
Yeah. So cyanosis. So it is in the neonatal period hyperoxia test. Just to mention, it's not nowadays very commonly used, but when the pulse, like there are some situation where we don't have echo and we don't know what the underlying thing is. So it is better to use this test, which is mentioned for decades in our textbook. This is so-called hyperoxia test. So you will get 100% oxygen by hood or by nasal prongs. Child is, if intubated, obviously you can give high FiO2. And then if there is rise in PO2 more than 200, CSD is unlikely. If it does not rise, then it is CSD likely. So in between 150 to 100 to 250, there is a range where it could be congenital or could be respiratory issues. But now, because the functional echocardiography is available in many centers, respiratory does not, plus PPHN may also behave like a congenital cyanotic heart disease. Many a time, I find very difficulty to these difficult PPHN patients. They just behave like TAPVC sort of PD shunting, torrential right to left, no response to this hyperoxia. How bad the lung, all depend on that. And the mixing cardiac lesions like non-obstructed TAPVC or single ventricle heart or truncus arteriosus, where saturation is on the lower side, but that rise PO2 significantly after giving. So increased pulmonary blood flow situation will go into high PO2 with high giving the high oxygenation. So these are the difficulties with DC, but still it's a very simple test. We can use if it is significantly desaturation is persisting even with giving the oxygen, then we can think of that it is most likely we are dealing with the congenital cyanotic heart disease. So congenital cyanotic heart disease being grouped into three categories. One is decreased pulmonary blood flow, that is the tetralogy of Fallot physiology, and the Eisenmenger syndrome. So Eisenmenger syndrome start as a left to right shunt, large left to right shunt in infancy. Then slowly the pulmonary vascular disease develop and it become right to left shunt and decreased pulmonary blood flow. So ultimately, top physiology and Eisenmenger will behave same if we do not intervene Eisenmenger on time. Then increased pulmonary blood flow situation, that is admixture lesion, transposition of great vessel, total anomalous pulmonary venous connections, and the complex congenital heart defect. Other group is the when your systemic vein, whether it is left SVC, right SVC, or IVC, dominantly connecting to the left atrium, so your desaturated blood is going into left atrium. Epstein anomaly, where it is not increased pulmonary blood flow, but because of tricuspid valve is so diseased, the PFO shunt right to left, and you have desaturation. And the pulmonary fistula. This Epstein anomaly could be, it's like even dysplastic tricuspid valve. After birth asphyxia, I have seen many cases where there's significant tricuspid regurgitation because of rupture of the chordae of tricuspid valve, and that behave like Epstein anomaly, torrential right to left shunt through the foramen ovale. they get settled with the initial hemodynamic management by the higher FiO2. So as pulmonary vascular resistance falls in newborn period after birth, so Epstein anomaly or TR because of any reason gets settled. So that is another so-called, it's not congenital heart defect. That tricuspid valve is because of the perinatal asphyxia, and that is not a rare entity to entertain. Clinically, history examination is very important. The family tells you that when the cyanosis is started, if they notice, like the case I showed, there was no history of cyanosis, but still we have to ask in detail. They will come to know, हाँ थोड़ा blue हो जाता है, थोड़ा blue दिखने लगता है. So ये सारी history mother may give you. Good examination is very important. That is head to toe examination. Here just I want to mention one patient I saw with 50% oxygen saturation, very sick child, 10-year-old, brought to my OPD. I was called in ICU for echocardiography. On oxygen, there was no increase in saturation. So I would think of clearly cyanotic heart defect. I did echo, it was severe tricuspid regurgitation, severe pulmonary arterial hypertension, no structural defect, and foramen ovale was shunting right to left, bad heart. And then after stabilization with the pulmonary vasodilator, child became perfect and came walking after 2 weeks with 94% of saturation. And the primary problem in that patient was obstructive apnea because of the very enlarged adenoids. So history is important, examination is important. You can't just miss even a throat examination in a patient which is coming to, whether it is cyanotic or acyanotic or respiratory issue or the neurological issue. So head to toe examination plus your focus systemic examination is very important in all patients, whether IPD or OPD. Use of saturation in the upper limb and lower limb is important. ECG will help you. Chest X-ray has its own importance, and obviously echocardiography will tell you everything beautifully with what disease you are dealing, whether it is congenital heart defect or it is functional issues complicating the situation. Cath, a cardiac MRI, you will require in selected cases, not in all cases. Chest X-ray, difficult to get a classical pattern like Sir said, clubbing. Clubbing take time to appear. Same way, classical chest X-ray findings takes time. So you won't get a classic top heart in newborn period. You won't get a figure of 8 appearance of TAPVC newborn. You won't get the rib notching for coarctation in newborn period. So X-ray changes are time-taking changes. Still, X-ray will guide you whether you are dealing with a serious congenital cyanotic heart disease. That will definitely tell you milder or moderate type of category you may miss on the chest X-ray. So what are important things to be look on chest X-ray? Visceral situs, cardiac position, very important. If there is discordance in situs and cardiac position, you are going to most likely with the congenital cyanotic heart disease, which is likely to be complex, more complex. Very dark lung or increased pulmonary blood flow or venous hypertension and sometimes localized pulmonary fistula in these x-rays you can, and obviously parenchymal lesion, and at the same time looking at the bony mark. So if there is hemivertebra, okay, you will come to know that this is one congenital anomaly in chest x-ray. Maybe you are dealing with the other congenital cardiac anomaly in the patient. So this is a chest x-ray, a newborn baby with severe cyanosis. Obviously it is anybody can say the central liver, the mesocardia is there, lungs are black. So it's clearly there is no need of hyperoxia test in this patient. This is a congenital cyanotic heart defect. You may give oxygen just to initial stabilization because saturation is 50-60. You may try to get a 70-80 with oxygen, but it is a congenital cyanotic heart disease. We need to emergency echo is needed. We need to deal with this patient in emergency. Another patient, another newborn with the cyanosis with low saturation around 80-85%. Again, in this chest X-ray, there is no cardiomegaly and lungs are hazy. So so-called ground glass appearance is there, which is a case of the obstructed TAPVC. Non-obstructed TAPVC, you won't get this picture. And other thing is your RDS, your HMD will almost give almost same type of picture. And here, in that situation, your hyperoxia test will help you. This is a cardiomegaly, a patient with a VSD, pulmonary arteries intake septum, and this patient was having severe TAP. Any valve regurgitation in newborn period will lead to cardiomegaly. So if cardiomegaly is there in neonatal period, it is not a shunt lesion. That we all need to understand. It is means valve regurgitation whether it is tricuspid regurgitation, which is very common. It could be Epstein anomaly, dysplastic pulmonary valve, or underlying tricuspid pulmonary atresia type situation, or it is aortic regurgitation, or it is Toff-Epstein pulmonary valve. So valve regurgitation, we need to think on that. So cardiomegaly is not ASD, VSD, or PD situation. Cardiomegaly means valve regurgitation that echo only can help you to reach the diagnosis. Different valve regurgitation need different line of management. So echo is very important. Again, one newborn with 60% of saturation, lungs are so clean. Lungs are so clean, but heart is, there is right atrial enlargement. What is, look at the borders. If you compare with the previous X-ray, very sharp borders. Very sharp borders are of in Epstein anomaly. And this X-ray, if I request the students to keep it, remember in your mind, this X-ray is of Epstein anomaly. These sharp borders are very much classified for the Epstein anomaly because of right atrial enlargement.
Ma'am, 1 second, I will ask you questions
Yes.
about the X-ray. Like in your experience, if it's cyanotic heart disease and cardiomegaly, how common it is? Like it's very uncommon to find a cardiac disease, cyanotic heart disease with cardiomegaly. I'm trying to say people start saying there's no cardiomegaly on X-ray, so it's cyanotic heart disease ruled out. On the contrary, we don't find a cardiomegaly, lot of cardiac disorders in newborns in cyanotic heart disease. But in truncus, TAPVC, later on you find a cardiomegaly when there's obstruction or something. Otherwise, in first 2 weeks of life, the
Yes.
cardiomegaly will not help you. Is that okay, ma'am? Do you think so?
Newborn, one is cyanosis, then newborn and the grown-up. Okay, so we have cyanosis with two categories. The commonest cyanotic heart defects, tetralogy of Fallot for the older kids, you don't get cardiomegaly. Commonest cyanotic in newborn is TGA, you don't get cardiomegaly. Okay, if there is cardiomegaly, it means something else is adding. So it could be TGA, but your valve is bad. So it has to be fetal damage to the heart for the cardiomegaly to appear. So, and it is the AV valve regurgitation. Fetal cardiac failure or neonatal cardiac failure. Cardiomegaly means there is cardiac failure. So cardiac failure from fetal to the neonatal life is AV valve regurgitation. So Epstein is one cause. Epstein with right to left shunt obviously will be cyanotic. So we have to think for the usual congenital cardiac defects when we are having a newborn with cardiomegaly. In general, if I say TGA, obviously no cardiomegaly. If I say TOF, no cardiomegaly. Pulmonary atresia, no cardiomegaly. It has to be volume load because of valve regurgitation leading to cardiomegaly in these patients.
And second thing would be about murmur. In a newborn, cyanotic heart disease, murmurs are normally not seen in first week, first 2 weeks. So you don't have a cardiomegaly and you don't have a murmur. These are two things which are very common, which you think that these are there, that is a CSD. But most of the times in newborn cyanotic heart disease, these two things are not there. Murmur is not there. Heart sounds loud. You can't appreciate the tachycardia most of the times. X-ray most of the time it doesn't show a cardiomegaly, and PVR issues will not allow you to have a plethora also. So really we have to use our sixth sense to suspect a CSD and not based on the routine cardiac findings.
That is pulse oximeter. So here comes the value of pulse oximeters. Pulse oximeter at the time of discharge, all babies upper and lower limb saturation. Neeraj, I would like to share one patient here, a newborn, 1 month of age. He was admitted in Meerut with the saturation of 90%, 85-90, and I was called for echo. Born there only, good nursery is there, okay, and documented saturation on the paper was 95 to 98. There was no desaturation mentioned, and it was now 85 to 90 on oxygen. I was called for echo, and it was a obstructed TAPVC. Then I told the neonatologist, how could you miss this obstructed TAPVC? It was born in their nursery. We have a discussion there. I took out all the papers, and it was documented there now. Like obstructed TAPVC infradiaphragmatic, the flow pattern is that way. Your IVC flow is going to the upper limb, and the superior vena cava IVC, which is carrying a high oxygenation level, will basically supplying your upper body. And if you are taking the saturation in the upper limb, you will get a much better saturation. So 95 above 90 is you can expect. But if you don't check, again, differential saturation. So if you don't check lower limb saturation, we will miss. So it is not the fault of the NICU staff. They documented a good saturation, but we missed the entity because child was comparatively stable. There was PDA shunting right to left, and maintained heart. But because of some feeding issue, readmitted, and when saturation was checked, it was on lower side. So these newborns are very difficult setting, especially when PDA is there. Many of the things may be hidden. We have to have a very strong suspicion in all babies, because congenital heart defects, commonest type of birth defect, to pick up them we have to have, because majority of births are now hospital. If still we are seeing grown-up congenital or beyond infancy, means we are missing that at the time of nursery, because they are stable that time. So double check is very important to pick up these babies. And even double check, baby remain in ICU for 3 days, but was perfectly fine. And I can explain that thing, good normal saturation at the time of discharge, even in obstructed TAPBC, because we did not check the lower limb saturation. So things can be explained. Upper lower limb both are important in newborn before the time of discharge.
Yes, madam, very good. I think the need of pulse oximetry is again stressed in assessment of congenital heart diseases.
Yes, sir. And NADA's criteria is obviously that says all these points Neeraj is telling, and those are not applicable in newborn period. It is our machine monitors which are important there to detect these babies. So in continuation with chest X-ray, this is diaphragmatic hernia. We all know, and fetal diagnosis, neonatal diagnosis, and the surgery is the answer. Diaphragmatic hernia, they present obviously with the severe pulmonary arterial hypertension. After surgery, you expect the PA pressure to come down, but in a particular percentage of patient, PA pressure remain elevated. So it is important that whatever early you intervene these babies, a particular number, 5-7%, may have persistent of pulmonary arterial hypertension, which require follow-up or the medication. So long-term follow-up even after this surgery is required in these babies, even there is no underlying congenital cardiac defect. Coming to ECG. ECG in newborn, it's a difficult thing. Many of time, the ECG technician is not comfortable of taking ECG in newborn. We don't have machine, we don't have electrode. So just to say we don't need different ECG machine for these newborns, same ECG machine, just we need to remove the clutches and put the leads directly over the baby, over the chest like this, and put it, fix it with the micro port to get the ECG. So we don't need a separate ECG machine. Most of the time it is sinus rhythm. All newborn, you have right axis deviation, right ventricle hypertrophy. This is a norm for the newborn. With congenital cardiac defect, this is so you by ECG it is difficult to differentiate. But if there is variation from this right axis deviation or right ventricular hypertrophy, means you are dealing most likely with the congenital cardiac defect, could be serious. So any adult pattern of ECG in cyanotic baby, we have to be alarmed, and we should go for the cardiac evaluation. So any adult pattern, any discordance between axis, your left axis right hypertrophy or right axis left ventricular hypertrophy, means there is high chances for underlying cardiac. In fact, it is there. Or any undue bradycardia or tachyarrhythmias, echocardiography is needed to know the underlying cardiac condition. So ECG is helpful, but if you it's at least a rhythm strip we should take, and it is not difficult to take ECG in newborn period, just to make your technician to be comfortable with the newborn and the machine. That is the only thing we all need, and that only can come if we start asking for ECG. ECG is one of the investigation which is very underutilized in pediatric practice, so we have to make it more. It's like hardly 100 rupees investigations tell you a lot. Like chest X-ray tell you a lot, same way ECG tells you a lot. If echo is not available, ECG we all can keep in our ICU. This is another important investigations. Coming to echocardiography, this is most important modality, tell you all black and white what we are dealing with. The transthoracic echo in pediatric age group tells you everything. If the things are not explained by routine echo, we go for the contrast echo to explain the low saturation in these children. So coming to few cyanotic congenital cardiac defects, one is the commonest cyanotic heart defect is the tetralogy of Fowler. Under that, a lot of things are there, so-called is a TOF physiology, where you have a large ventricule-septal defect and the decreased pulmonary blood flow because of pulmonary stenosis. So TOF, which tops the list, then DORV VSD-PS, TJ VSD-PA, corrected TJ VSD-PS, AV canal VSD-PS, single ventricle PS. So these are all the echo diagnosis. Clinically, there is only one group, that is tetralogy of Fallot physiology. With that, we can start our management, medical management, and obviously the surgical, all cyanotic heart defects are the surgical cases. Ultimately, we refer for the surgical intervention. But for the pediatric level, this is TOF physiology is important for all of us to recognize clinically. So this is decreased pulmonary blood flow with good intracardiac mixing at the level of ventricle septal defect is defined as tetralogy of Fallot physiology. The presentation usually later in infancy, they come with the, so we have discussed with the cyanosis or cyanotic spell or squatting. This is sort of presentation. Otherwise, they are comfortable patients. Weight gain is fine. There are no recurrent chest infection. They're just doing fine. Almost 25% of tetralogy Fallot physiology have a genetic issue. So syndromic association is there. That will complicate your weight gain and the other presentation. But otherwise, tetralogy in isolation, the presentation is very smooth presentation. No CHF, and sometimes they just come with the CV and brain abscess. This child, 8-year-old patient, admitted in the neurosurgery in Medanta with the neuro issues for the headache, and he was found to have big brain abscess. Then because saturation was low, we were called and it was tetralogy of Fallot. So then he was operated for brain abscess. 6 weeks after the brain abscess treatment, he underwent tetralogy of Fallot correction. So this is the thing happen. It is not uncommon that they're coming something very serious neurological complication for because of underlying congenital cyanotic heart defect. So diagnosing these patients on time become our priority, and that is at the time of discharge, checking the saturation and clinically examining. On examination, there is no cardiac enlargement. Second heart sounds single. There is ejection systolic murmur of various degree, usually 2 to 3 by 6. And the more the cyanosis, more the PS, then your murmur become smaller. So the sicker the tetralogy, you have the less serious murmur. With pulmonary atresia, no murmur. So more sicker child, lesser the murmur. It is always inversely proportional to the presentation, to the underlying condition. So X-ray is usually this. You all know this boot-shaped heart. Boot-shaped heart means it is RV type of, and when RV enlarged, it just turned towards the left upturned apex, leading to this particular shape. So just to mention, no cardiomegaly, RV type of apex, and there is pulmonary. This emptiness is because this is the place of the pulmonary artery, and it is empty because pulmonary arteries are not prominent in this in all tetralogy of Fallot patient. And this is autopsy, this is echocardiography. You see a large ventricoseptal defect. This is pulmonary flow, which is narrow. So echo will tell you everything, how pulmonary artery, how coronaries, any associated defects. So many things will get on echocardiography. It is surgical entity. The neonate with severe cyanosis, if they are, it is usually very critical PS or pulmonary atresia, and we need to go either BT shunt or ductal stenting. Later, they go under total correction. If child is stable, saturation more than 75% around, elective total correction 6 months to 1 year is needed. When there is need of conduit, like there's so many entity in the TOF physiology, like transposition of great vessels, you need to put an artificial tube, or when pulmonary atresia, you need to put artificial tube to connect RV to the pulmonary artery. Then we try to delay the intervention to 2 to 4 years of age, because this conduit becomes smaller with age. So just to reduce the number of intervention, we try to get more time in these patients. If child is sick, recurrent cyanotic spell, low saturation, you need to go for the early intervention, whether it is surgery, total correction, or BT shunt. All depend on what type of anatomy it is, but it is a surgical entity.
Ma'am, one second, sorry.
Yeah.
We have Dr. Deepa ma'am also in the session, chairperson. And let us discuss for some part of TOF physiology, like how are we, Dr. Deepa ma'am, you are around? Dr. Deepa ma'am?
Yes, sir. Yes.
So how frequently you see TOF physiology in your setups? What do you do? Like, do you refer them early for early surgery? How are the surgical systems available in Maharashtra for TOF surgery in government setups? Where do you send them for surgery?
Yes, we do get many cases of congenital heart disease as such, and a few cases of TOF. Basically, being in a government medical college, we are having very less facilities, whether it comes to an echo or a pediatric cardiologist opinion. So what we do is we have an MOU with the pediatric cardiologist who visits our center, and then we get the investigations done. But then again, it becomes a problem to refer these patients. So we have few centers in Mumbai, government centers, and a few centers in the private hospitals who do take these patients, and under certain schemes they operate. So we have contacts with these people, and then whenever we need referrals, we send these patients to the higher centers.
Yes. Yes, ma'am. And students keep seeing the top patients, but they know what is the
Yes,
outcome. They don't know because they don't come back to the students.
yes,
So
yes,
they have never
yes.
seen outcomes of top surgery. That's why I was trying to talk to Dr. Munish ma'am. Top surgery nowadays have excellent outcomes. So in our setup in Delhi and our surrounding areas, mortality due to TOF is rare. If it comes to the hospital for surgery, they will go home. It's very unlikely that they're not going home nowadays, and they will live normal life. You do it correct at right time. Ma'am, you have shared a slide that you correct the total correction at 6 months to 1 year of life. So I just want to correction for the students. Lot of students think that you have to do shunt first, then complete repair. Can't we do complete repair together? Can't we go for a single stage repair in all the patients? This correction, clearance I want from you, the confirmation that we can do complete repairs single-handedly, or you have to do the staging always. That is the question for the students, sir.
Yeah, we have to. If you look at the US, okay, they go for total correction. They don't go for stage surgery. So there is no financial constraint. If we do neonatal repair in tetralogy or pulmonary arterial situation, the ICU stay is almost 1 month, 2 weeks, 3 weeks, 4 weeks, and the morbidity is definitely higher if we do neonatal intervention. So if we can buy time by doing a palliative intervention, whether it is BT shunt or ductal stenting, नहीं मेरे उसका, so we can sort of we have to adjust our finances also. So that is the importance. So US, UK, they go for total corrections. It is not that it cannot be done. TGA are being operated in neonatal life only. It is a very big surgery, major surgery. You have to do switch, coronary, everything. We do because TGA can be done in newborn period only. Now, ये नहीं है मेरा. Now for the tetralogy, just because of that reason, we try to buy time. It's
So
not
madam, that means that the pediatricians should know the facilities available in the local area regarding the transmission of great vessels, or say phallus tetralogy particularly, whether if they have very advanced facilities, then in their own hospital, and where they should refer it. Say in West Bengal, we have 2 centers in the government setup, and then if they are not able to accommodate all of them, then they have a referral system with insurance coverage to a private institute. So these must be known to the pediatrician so that the patients do not suffer unnecessarily. They get the proper treatment, whether it could be done within 6 months to 1 year, or they need to be a little delayed, and some supportive sort of two-stage surgery could be done. So that is, we all, the pediatrician must know it. That's a very important message, I think, you want to say here.
Yes, sir. Yes, that is true, sir.
Thank
So in our setup, like in Delhi NCR, lot of units perform complete repair if the child comes beyond 3 months. If child is coming beyond 3 months, they will do complete repair. And most of units, if child is coming in less than 3 months, they do palliate. So that is the understanding in Delhi NCR area. As ma'am says, few units can do earlier also, but not lot of units don't want to do it. So
Yes.
Munish ma'am, we can continue, I think, the class. Ma'am, I think you are muted. I think you are muted, ma'am. We can't hear you. We can see the screen, but we can't hear you.
Okay, sorry.
Yes, please unmute. No,
So, few words about the cyanotic spell, the medical stabilization, and the most important thing which I feel is managing these cyanotic spell babies is giving them comfort. So don't take the baby from mother, which is I feel is very important. Tell the mother how to hold the baby's knee chest position, and if still things are not, so we can just give a mild sedation to these babies. Then, if not stable, then we admit them. Hydration is important, correction of anemia is important, beta blocker is important. Very sick babies still not managed by majority, 90% are being managed by this management only. Hardly we require ventilation for that, but still, if things are not getting settled, they go for the ventilation. You don't require inotropes for these babies. You just need to maintain the hydration. That is very important. Inotropes, whatever the inotropes you are using, will increase your heart rate. Increasing the heart rate means you are making them more sicker. So controlling the heart rate is the any type of heart disease. Actually, we as a pediatrician should understand that tachycardia will deteriorate your cardiac patients. So whether it is CHF or whether it is the cyanotic issues, tachycardia should be prevented, should be avoided in cardiac patients. So use of inotropes, lots of inotrope should not be there in these patients. If there is because of severe hypoxia, there are convulsion, you can use the benzodiazepine for the treatment and the palliative or the total correction as we all discussed. If we do not treat these patients on time, so a long list of complications presentation is there, and we do all see grown up congenital cyanotic heart defect with tetralogy of Fallot physiology. Like I said, cerebrovascular accident, brain abscess, rhythm disorder, hemoptysis, they come with the massive bleeding into the OPD, and a long list of complications is there. Untreated tetralogy of Fallot survival is 1 year. This is the only cyanotic heart defect which the longest survival to the infancy. So 66%, majority will we lose in the in infancy only. So 10 year is only 25%. So this is the sad status of the tetralogy of Fallot if we do not treat them on time. If we treat them on time, majority live a acceptable good quality of life. Coming to admixture lesions, so they present with the early onset of cyanosis because there is increased pulmonary blood flow. They present with features of congestive cardiac failure, weight gain, and cardiomegaly on chest X-ray. The commonest neonatal cyanotic heart defects is the transposition of gate vessels, where your pulmonary artery arising from the left ventricle and the aorta is arising from the right ventricle. In this situation, the child cannot survive because your whole of the systemic blood flow is going to the aorta and the oxygenated blood into the pulmonary artery. You have to have communication in between, and that is the reason they survive, whatever number they survive. So commonest being the interatrial communication, you may have VSD, you may have PTA. So any level of shunt is needed for these babies to survive whatever days or months they have with us if we do not intervene them on time. These are the chest X-ray. This is with the intact ventricular septum. This is with with PDA, which is 3 weeks old, and this was with 50% saturation, so-called very comfortable baby with 50% saturation. It was congenital cyanotic heart disease (TGA). This was again 3-week old with VSD, and this X-ray is very typical of TGA, which is we all read as agon side appearance, while this X-ray and this X-ray do not fit into typical TGA patients. So X-ray may be typical, may be atypical. So X-ray will tell you something is abnormal. More important is clinical. X-ray may add to your value, may not add to your value, but obviously should be utilized to reach the diagnosis. To guide you towards the diagnosis. Echocardiography will tell you everything. So this is subcostal view, this is left ventricle, pulmonary artery, this is right ventricle, aorta. So that will tell you everything left, right, where the mixing is, what you can do. And here it is the in a sick patient, the balloon atrial septostomy is being done. Tiny interatrial communication being enlarged after the balloon atrial septostomy. And this we can do bedside only. This is under fluoroscopy, but bedside treatment to initially stabilize these babies is there. So you can, basic management for all newborn is fluid electrolyte, temperature maintenance, prostaglandin infusion, sick babies, and you transfer them to pediatric cardiac center. Balloon atrial septostomy, pediatric cardiologist there in your city can do it, and earlier arterial switch. Early arterial switch means it is we have just within a month, we need to treat these babies. So we have a very short time for the transposition of great vessel babies. We do not intervene them on time. Then you go for the 2-stage arterial switch or staining operation. No, this is very high risk option. This is not a very great option. So this is the best time we have with us to intervene these babies and to save these babies. When this large VSG or large PDA, we have some more weeks with us, like 1.5 months, but surgery has to be done, and that is within 1 to 3 months of age in all patients. TAPVC, you have all pulmonary veins forming confluence and joining somewhere into systemic vein. It can be to the IVC, it can be to the SVC, anywhere. Wherever it is, you can define by echocardiography. If it is with obstruction, like in this turbulence means it is obstructed. Emergency surgery, if non-obstructive, elective surgery, but it is surgery only. There is nothing like medical stabilization in these patients. Medical stabilization means neonatal care. So just an ICU care, fluid electrolyte balance, and then you go for the surgery in these babies. Single ventricle, complex situation when you don't use both ventricles and you have to go for surgery in a staged pattern in these babies. This is the survival of children born with the cyanotic heart defects. So if they are unoperated, so TGA, only 20% survive one year. TAPVC only 18. So it is only tetralogy of Fallot visual 65 to 70%. Majority of whatever cyanotic heart defect, if you do not intervene, you lose by the first birthday. So that is the importance of diagnosis them on time and intervening them on time. So there are a few case scenarios would like to share with you. This is a 2 days old baby, 36-week gestation, IUGR, LSCS for fetal distress, and the saturation was 80% oxygen. For respiratory distress, I was called for echocardiography. And what it is there, this is PPHN. So this is torrential PDA shunting right to left. The baby was on HFO for the respiratory issues. And this is isolated PPHN. So echo will tell you what you are dealing with. And you can obviously optimize your medication according to your underlying cardiac conditions and baby stabilize. This is another newborn where I was comparatively stable baby, just on a routine ICU admission, and here was cyanosis. So I was called for echocardiography, and here the cause was PFO right to left, means saturation low you expect, but RV was hypertrophy. So it was just isolated right ventricular hypertrophy to cause desaturation. You don't need anything. Just by next 2-3 months, baby becomes stable. You don't need any medication. You just need to counsel the family. Other case is the 36 weeks, just borderline preterm with IGR, and again he was shifted for cyanosis, severe low saturation 65%, and this was chest X-ray, just usual. You don't see anything very alarming, but what I could see is abdomen was bad. Hardly any air gas pattern is seen there. So X-ray means cardiac is important, lungs are important, but abdomen is also when you are looking from the newborn point of view. Echo was sick echo. It was severe pulmonary arterial hypertension. And what was the culprit? It's a big thrombus sitting in the pulmonary artery, which was causing practically, it was blocking the pulmonary circulation. So the cause was something acquired cause related to his birth asphyxia, and child underwent streptokinase was given, and complete dissolution of the thrombus was there after treatment. So this is the beauty of echocardiography. If we need to use it smartly, we need to rule out the congenital structural or the acquired or the hemodynamic factor also. Accordingly, we have to optimize our medication. So neonatal arterial thrombosis, not very rare. Probably we do diagnose lesser number, because when baby is very sick, only the intervention or echo is being done. Otherwise, borderline cases we may be missing. I could diagnose only 5 neonatal thrombosis presenting with the severe pulmonary hypertension and large thrombus requiring the thrombolysis in these patients.
Ma'am, sorry for the interruption. There is a question also. There is a message in the MacBook, low battery. So please you charge your MacBook first thing.
Yes, that is important. I'm seeing that signal. Your system is low in battery, so that needs to be taken care of first.
Low battery.
And the time
phone is in low battery. Speaker is in high battery.
Yes. And presence of Dr. Pankaj is again reminding us about the time also, I think.
Maybe 10 minutes because we have to take some questions also.
Yes,
So we
yes,
can always take liberty because of being online. So we can always take liberty of 10 minutes
yes,
extra.
yes, definitely.
There is a question on the question answer box. Till we'll try to answer that question till the ma'am joins us back.
Yes.
In a neutral patient with severe TR, with severe PH, and BD shunting atrial. So that's a PPHN basically. RV dominance, D-shaped ventricle. So that means want to say there is severe PH basically. Is there any role of other medications besides sildenafil? I think we'll cover the topic of PPHN and PH in the next sessions. But ma'am, can you answer shortly so that we can move ahead with the book? We're lacking time now today actually.
Yeah, so that was PPHN. There was no doubt about echocardiography because we confirmed it by echocardiography. Medication means the approved, FDA approved is the nitric oxide, which is obviously not available everywhere. Now comes the sildenafil, now comes your milrinone, which is a pulmonary vasodilator because that support your heart. So in this situation, the medication will be dependent on your whether your BP is maintained or not. If blood pressure is maintained, you easily use milrinone, and just with respiratory settings and the things, you will try to stabilize your hypotension is there. Obviously you have to give a touch of noradrenaline to because the mean pressure is needed. You just so very smartly using these inotrope and vasodilators are needed in these sick babies. That baby was very sick on HFO and on nitric oxide, sildenafil, so many things. But they come out if we smartly use our medication in these babies. I have just 2-3 slides. So another is a 2 weeks old baby with cyanosis for 1 day. 2 weeks with cyanosis for 1 day. So history is so important. Saturation 70%, and there was no murmur except he was tachypneic. He was irritable, and he was sent to me for echocardiography. There was no increase on oxygenation. That is again important. Chest X-ray unremarkable, and my echo was normal. So what we have to think out of the box also. All 70% saturation are not TGA, TAPVC or the tetralogy of Fallot. We have to think for the non-cardiac causes also. He was on bottle feeding, on vomiting, and started on perinorm drop thrice daily for vomiting. And this was his blood gas. So methemoglobin was 37.5%. This was VBG because in emergency I could do that. And this was the methemoglobin, and he was treated with methylene blue. And just with one dose, the saturation increased to 95%. So cardiac, yes, we always have to think, but simultaneously respiratory and the hematological factors should always is. Like mother was very clear, he's blue only for 1 day, he is irritable for 1 day, he's having distress for 1 day. So cyanotic baby is not always happy. When they are irritable, they come like this. So short history is important, means history is important, examination is important, and further evaluation, all modalities should be used, and blood gas is obviously simple investigation everywhere is available. Methemoglobin sensor should be there to diagnose these patients. So methemoglobin, when to suspect? When there is sudden onset of cyanosis, drug history or something, ingestion of that particular agent you will get on. Hypoxia do not improve with increasing FiO2, and drop of blood that will give you chocolate or brownish discoloration. Even if you don't have blood gas, obviously you can diagnose this thing bedside investigation. Treatment is methylene blue, and you have to stop the culprit agent in these patients, ascorbic acid, and the blood transfusion or exchange transfusion when it is very high, more than 50%, child is 6, you may require these things. But methylene blue, whenever I saw these patients, act wonderfully to save these babies. This is 5-month-old with cyanosis again, and he was treated as pneumonia. So this was the patch. He was treated for pneumonia. Echo was normal inside echo. Then I go towards the saline contrast echo. Just we give a saline, agitated saline from the venous, and there is filling of the right heart, then left heart. Normally, when there is filling of right heart, this white, this is the saline. It does not go to the left heart because the lung act as a filter for that. When it is not filtering, so it is appearing on the left heart, and it is not inside the heart because it's coming after a time to the left heart. So that is the case of the pulmonary AV fistula, and this baby underwent device closure for the pulmonary AV fistula. So these are the treatable causes with exist without the murmur. So whether it is acquired like methemoglobinemia or pulmonary fistula or TG or T, there are many things for these cyanosis to be explained. Just we have to have a smart approach with history examination and smartly use of the modalities to reach the diagnosis and accordingly guide them towards the treatment. So child with cyanosis, don't get panic. Always have a systematic approach, good history examination, chest X-ray interpretation, early use of the echocardiography, and think for the less common causes if saturation is still not explained by the echocardiography. So if I do echo and labeling a normal heart without doing contrast echo or without checking the VBG, they will lose these babies. So me as a pediatric cardiology have to answer you why the saturation is low. So whether it is intracardiac or extracardiac, we all have to answer related to that. Thank you.
Thank you so much, Dr. Munish. Yeah, Dr. Neeraj, please, your comments.
So excellent session, ma'am. As always, it's always you enlightening to hear you, ma'am. Always, I like your lectures, and I try to attend all your lectures whenever you are giving classes or something. You'll find me there. So, for the students, we got a good message today about the cyanotic heart disease. That pulse oximetry is very important. The treatment has to start early. Echo has to be done in all cyanotic heart disease patient as soon as possible to go ahead. Ma'am, one more question for all the chairpersons, also for the speakers also. Do we train people to screen heart disease? Like it's called POCUS nowadays.
Yes.
Which is not bogus, it's POCUS only. So so do we expect the neurologists to learn POCUS to the new generation? Because everywhere you and me are not available, ma'am. So PIDS cardio are not available everywhere. A lot of people don't want to come to PIDS cardio nowadays, as you understand. So do we train them for screening? Like, do you find a value in that part? And how difficult it is to train for screening echo, CHD screening?
Honestly, Neeraj, one is we all are at same level. So anybody can be trained into any modality. So whether it is CT, MRI or echocardiography, these are just technician job practically. If I can learn, anybody can learn. But if one is learning, it has to be in-depth learning. I don't like the word screening echo because that screening means you are guiding them towards a treatment. You are so if me as a person is not doing in-depth echo, I will miss many things like coarctation of aorta. We have adult cardiologist group. These things are they are trained in echocardiography, beautifully trained in echocardiography in their field, but because pediatric cardiology is not their area, over the time they get detached from that particular side. So we do see patients of coarctation being missed, TAPVC being missed. It is not because they don't know echocardiography. It is not. So if there is training, it has to be in depth, because getting these patients, diagnosing these patients is their job now. If someone is doing screening, he or she cannot afford to miss infradiaphragm, cannot afford to miss pulmonary fistula, cannot afford to miss vein of Galen malformation, which could be presenting like a cyanotic CHF type of scenario. If you are learning, you have to learn properly. And anybody can learn. There's nothing that they are into a program, they only can learn. Anybody can learn. This our technician do very great job for echocardiography. One of our technicians there with me in Satyasai, her echo was so good, means blindly I used to write prescription based on her echocardiography. She's so anybody can be trained. Just we have to have that focus, that I have to learn in depth. There's nothing like screening echocardiography. सब कुछ उसी पे based है. आपकी screening echo type based है.
I fully agree, madam. I fully agree that let all of us be acquainted with the use of pulse oximetry first, and then the next stage is the point of care ultrasound. Now, that is very important. We can get the anatomy definitely, but unless we are rather I should say more focused to become a pediatric cardiologist, it may not be necessary to learn the POCUS technique from the beginning. But those who are more inclined will gradually get this sort of interest being ultimately transformed into skill by the focus trainings. And IIP is also organizing this sort of focus trainings in multiple cities. In our state, we are organizing it through IIP. So that is another stage that, yes, Neeraj has rightly mentioned, that must come in our practicing field gradually. Thank you, madam.
Thank you, sir. So especially in the medical colleges, we can just define one person. Then that things can start from medical college. So
yes, now I will definitely, yeah, I definitely agree with this, and I'm quite taking an initiative in this. Basically, we do have ultrasound machines, but we don't have the trained person. So we have a pediatric cardiologist who comes to visit our center, and what we do is I keep on keeping his sessions, specific training sessions for the PG graduates. And recently, now in June, our medical college, our department has taken an initiative, and we are organizing a focus session now. And we are getting all the PGs from the nearby colleges. And even I've given one topic to my postgraduate, the utility of focus in treating critically ill patients. So I feel that focus is becoming now a very useful tool, not just for cardiology, but in an ICU to treat all the critical patients. So I think IIT should come up with this focus that can be taken at all the peripheral medical colleges, so that the PGs get trained, which is now very much a necessity for them to tackle the critical patients.
So,
I think, Dr. Neeraj, I had one thought about this, that as we are saying for many long time that we don't have many pediatric cardiologists and the problem is going to persist. And we also know that now artificial intelligence is coming in a big way for many sections of medical care. So is it possible that over a period of time, the standard ultrasound sections or views which are captured by any one of us, and then it is through AI technology, you're able to diagnose. Is that option open for pediatric cardiology scans also? Or it is something which is very far-fetched.
So, sir, actually, we use it in our setting, but as ma'am says, no, views, someone has to make the great views. They have to be acquainted, like someone is, like in our ICU, like we do with our fellows, they know what views we want. And we tell them on WhatsApp video calls that rotate the probe like this or this, and we are able to diagnose a lot of disorders. Like common disorders in newborn, cyanotic heart disorders, we're able to pick up nowadays. As you see in our ICU also, in our you are an ICU basically, all our fellows do the focus program, and they do echo routinely in our settings. So in the night also, I have reduced my comings to the NICU nowadays compared to 10 years back because of this setting only. So, but people have to come to a system, like someone has to be affiliated to ma'am, that she will guide him for 2 weeks in the setup, 3 weeks in the setup, and then they go home. They keep talking to her for next 2 3 years, and then these programs can develop. That is the really a feasibility and possibility. Now regarding the focus program, screening program, which I call, lot of patients we have diagnosed by screening. Like in periphery, one patient was diagnosed with, he says there is a distress in the cardiac respiratory distress. They did the focus program, they did the LV dysfunction. They said there's the LV dysfunction. They say something is wrong here. So they sent the patient directly to us for further evaluation. We found coarctation, we did a surgery. But if he doesn't know how to pick up LV dysfunction, then this patient would not come to us. They will think this is respiratory distress. They will keep managing and wasting time. So uncommon disorders will not be picked up by the AI, by the distant learning programs, but common disorders like TGA, supracardiac TAPVC will be picked up. So these lesions, coarctation, single ventricle, the TOF, VSD, pulmonary atresia are picked up by the focus team also nowadays. In our NICU, our fellows are picking up. Those are who are doing DNB in NICU in Gangaram, they are picking up these disorders by the focus screening. They call us that something is wrong. You come in the morning or in the night today. So we have found a good results. Actually, myself has found good results with the focus training program.
Yes, I do agree with this, sir. Because even our students, because now we are training in theory, They at least call and see, tell us that, ma'am, I have done this and I find this something is wrong with the cardiac function. So
Thank you so much. I think
that's
in the
why.
interest of time, we can take some questions also. There's some I can see in the questions.
Uh, Dr. Deepa ma'am, let Dr. Deepa ma'am finish what she was saying. Ma'am, please.
I just agree with that, that focus is very much useful and it helps in early recognition of these orders so that we can refer them early.
Thank you, ma'am. Thank you. Munesh ma'am, there is one question only.
Yeah.
With low saturations, we use oxygen as support in newborns. But without clinical signs of heart disease, so should we continue oxygen as oxygen may close PDA? So what is saying that in a cyanotic heart disease where duct dependent lesion is there, if you give oxygen, PDA might close. So what do you think about this part?
Like it's more of a misconception.
Yes.
In a term baby, oxygen is not going to do to close the PDA. Close, so that happened with the first breath of the baby and whatever is. Now, when there is plus minus desaturation or something, giving oxygen will close nothing like that. So you can safely give oxygen from that point of view till you are waiting for your echocardiography. Obviously, when things are not explained, not improving, you have to go for echocardiography. That is the thing. But oxygen can be given. Like just one comment about this. Like Neeraj, when we create a group like for focus, if I am in touch with the 10 people, they will always share the things with me. I have some doubt. Can you answer that? And we can guide them. Problem comes when this is being done as an independent modality. Problem comes, and it can happen anytime. Anybody can think. Then I have seen the patient with DC, so-called DCM, and with LCAPA for 3 years. I have seen many things actually. So use of modality as a screening should be used that way, and accordingly timely should be referred. It is issues when we are in touch with our core group. We are happy. We do guide them. Beyond that, we don't have control. Anybody can think that I am now a specialist.
Yes,
So
that the concerns are there. Yeah, I understand that part. Yes,
always
that is
happen.
true. Self understanding what is the limitation of your modality. They have to understand that part. True, ma'am. That's true.
Something like this, we should, like, if I am means anybody, like it's not that pediatrician I'm talking about, it's in all the fields where up to where I should use this particular investigation, where I need to refer. Same is happening in the fetal echocardiography, means fetal medicine group, radiology group. Pediatric cardiology, I feel my value is for the consultation, for counseling family. They have very good images, but what to be done? So the input is very important, and from where you are taking, that is important. We should not block the things at the name of particular specialty. That is what I mean actually.
I think in the interest of time, sir, we have to conclude now. We can ask the chairperson to
Please
the
stop sharing the screen, otherwise it will in the recording.
Okay. We can ask the chairperson to conclude the sessions.
Well, it's a pleasure to be here in this session, and we really learned a lot even at this stage from Dr. Munesh. And it's interesting that we are going to add more and more, say, clinical investigational facilities to add on the diagnosis and management. So starting from the very good article that you have mentioned regarding the use of pulse oximeter, which we didn't had in our, say, undergraduate days, and then it came subsequently, and now it's routine clinical practice. Then the other things that we have already discussed, focus and all that, use of AI on all that. So these are very useful things, and I think we should continue this type of webinars, and we will be learning each other, and the facilities across the country in different cities and states are also different. So that could be a learning point for all of us to share also, that where is which facility is available, and whether if it is not available in Calcutta or some or in our state, then we can refer it to some other states. This knowledge we can also share in this forum also. Thank you, and thanks to the speaker once again, and my co-chairperson and the IIP president and the organizers. Thanks. I must appreciate you for inviting me to be present here.
Dr. Deepa ma'am. Dr. Deepa ma'am.
Yeah. It was an excellent session, and ma'am has very well stressed upon the importance of taking a detailed history and examination, and mainly the importance of taking the saturation, that is pulse oximeter. And even now with the NRP guidelines, they say that SpO2 is the fifth vital parameter. So we should not be missing out taking a saturation in a unit. And she has very well also told about the utility of the echocardiogram, bedside echocardiogram. And we need to train most of our PGs in this, and we should form a framework, I would say a network, where even with the peripheries also should be connected to such centers where we can help our poor patients also, and that can be taken care of by with good tertiary care centers, and we can help our patients. Thank you so much.
Thank you, ma'am. Thank you.
Thank you, Neeraj. Thank you, everybody.
So, at the last, I thank Dr. Neeraj, Dr. Mridul, and Dr. Jay. It's their navigation of this whole program, and it has been lined up so beautifully that everything is building up from clinical history, then X-ray, then ECG, now cyanotic heart disease, and I'm sure next time it is going to be acyanotic congenital heart diseases, and the discussion will follow. One thing very particular about all pediatric cardiologists are they are very passionate people. They're very passionate about their specialty. They're very passionate about teaching. And Dr. Neeraj and his team take a lot of interest in training our fellows. And I'm sure same holds true for Dr. MUNESH Tomar. And I have been knowing her for so many years, and her passion keeps on increasing every time I listen to her talk. So she's a very good orator, as well as she makes her point crystal clear by explaining it in different ways. So I'm sure these sessions are going to be very helpful. The recording of this also will be available subsequently. And I request that as well as possible, Dr. Munesh, please keep on joining our other sessions also for your important inputs. And last but not the least, I have Dr. Dinesh Goyal, who's our Joint Secretary. He's also is there. So I request Dr. Dinesh Goyal to say a few words and to offer vote of thanks for this session. Dr. Dinesh, please.
Thank you, sir. Am I audible?
Yes, you are audible.
Yes, you are.
Thank you, sir. Thank you so much. And such a wonderful session by Dr. Munish, ma'am. And thank you joining Dr. Sukanta and Dr. Deepa, ma'am, and from Calcutta and Kolhapur. And Dr. Sukanta, I am the Calcutta UG, and Dr. Sivarjan Ghosh is my teacher in my time.
Good.
I did my graduation from RGKR Medical College.
Well, come to Kolkata frequently then.
Yes. So I have a very special connection with Calcutta, and this session was a wonderful session, and it's basically eye opener to the beginners. And earlier we thought cardiology is a very big subject and scaring subject for the postgraduate students. But nowadays with the screening part, every PG student or a senior resident can screen the newborns properly, and then they can refer to the pediatric cardiologist for the proper intervention. That is the main purpose of this module. And thank you to Dr. Ajay Gupta, sir. He is very instrumental in conducting this pediatric cardiology e-course, and such a wonderful initiative. We have done a few courses in the past also, and planning few in the in coming future also. But it's definitely a learning for everyone, and learning never stops. So with this, I sincerely thanks to all of you for participating in this wonderful session. Thank you so much. Thank you so much once
Bye.
again.
See you next week.
Wish you a very happy Sunday. Thank you.
Thank you all.
Thank you.
Thank you
And
so
see you
much.
next
Bye
week,
bye.
same time, 9 o'clock. Bye-bye.
Bye bye.
Thank you so much.